Hello, everyone. We're going to get started in just a second. Hello, everyone. I'm Marcia Mott, the Health Promotions Coordinator for UF Health. Welcome to UF Health Wellness University webinar. Today is National Injury Prevention Day, and we have an incredible lineup of speakers. Our first speaker is Dr. Robin Petroze. She joined UF Health in 2018 as an assistant professor in the Division of Pediatric Surgery. She graduated with her medical degree from the University of Cincinnati College of Medicine and finished first in her graduating class. She completed her general surgery residency at the University of Virginia, where she received an NIH Fogarty International Fellowship to study access to surgical care, capacity for emergency and essential surgery, and educational development. During her fellowship, she lived for 2 years in Rwanda in East Africa. She subsequently completed her master's in public health at the University of Virginia. Dr. Petroze completed her pediatric surgery fellowship at the Montreal Children's Hospital / McGill University. She is a pediatric surgeon with a special interest in neonatal surgery, minimally invasive surgery, and surgical oncology. Her research, teaching, and advocacy focuses on access to equitable care in the underserved populations, both internationally and domestically, as well as patient and family-centered outcomes. We'll also hear from Dr. Fida Badaru. Dr. Badaru graduated from St. George's University School of Medicine in 2012. She went on to complete a general residency at St. Louis University. She's currently a pediatric surgery fellow at the UF College of Medicine. She enjoys her spare time spending time with her 3 children. Our final speaker is Dr. Jordan McKean. Dr. McKean is a first-year general surgery resident with the UF College of Medicine. She graduated from medical school at the University of Florida in 2020. She then immediately began her 7-year general surgery residency at UF. She's passionate about LGBTQ+ centered care and is the proud mother of a Chihuahua named Miss Nancy. It's so exciting to have a speaker lineup with these 3 outstanding women who are going to provide care for our youngest patients here at UF Health. If you have questions for our speaker, you can submit your written questions at any time using the Q&A button at the bottom of your screen. At the end of the presentation, I'm going to ask the questions that were submitted. This webinar is also being recorded, so I'll send out a link to the recording in a few days. Dr. Petroze, I'm going to go ahead and turn it over to you now. Thank you so much.
Excellent. Well, this is such an opportunity for us with the University of Florida Pediatric Trauma Team to present on National Injury Prevention Day. And what we really want to do is go through ways to prevent injury. All of the studying that we have done, all of the work that we do, we hope you never get to meet us at the hospital. I am incredibly lucky to be co-presenting with 2 wonderful surgical trainees who have a passion for health advocacy and in particular for child health. This is something that really gets them excited. And I think that our combined experience when we look at the kids that we treat in the emergency room and on the pediatric trauma service motivates our trainees to find ways to make care better in the future. So I'm very lucky to have Dr. Badaru and Dr. McKean joining us today. As I said, the goal is that you as a parent, as a pediatrician, as a community member, never have to meet us with the pediatric trauma team. But if you do, you should know that the UF Pediatric Trauma Service is one of the only Florida level 1 pediatric trauma services, certainly the one in North Central Florida, and it's a team effort. We work with pediatric surgeons and we do coordinate the care, but we have emergency medicine physicians, critical care physicians, specialized nurses that specialize in pediatrics and in trauma. We coordinate with orthopedic surgeons, neurosurgeons, plastic surgeons, pediatricians, our transport to and from the hospital with our critical care transport specialists, with Shan's Care, and with all of the EMS in the region, that we really work together to improve the care of kids in the community. We couldn't do this without social workers or without child life specialists, and we absolutely could not do this without our pediatric trauma coordinator, Amy. And how do we get better? Well, we collect data. And so we have registrars that record data on kids so that we can improve the care that we provide. Each member of our team is committed to delivering the highest quality, evidence-based care to every injured child. And this is from the moment the child arrives at UF Health through rehabilitation. Here's just an example of some of our ongoing training that we participate in. These are simulation events that occur in our pediatric ER. We conduct these in the adult ER, and we also engage with local EMS to help with the care of injured children. So why are we talking about injuries? Unintentional injuries are the leading cause of death for children and young adults aged up to 19 years. In fact, while that is the leading cause, in infants under a year, they're the third leading cause of death. Nearly 8,000 children die from unintentional injuries each year. And let's put this into perspective. That's 20 preventable deaths per day in the United States. 20 preventable deaths per day. When we look at our own data here at UF, and we look at our top mechanisms of injury that we see in trauma patients, the most common is falls. We see quite a few burns, and we certainly see motor vehicle crashes, ATVs, sports injuries. One of the things that I'm passionate about is looking at access to care. Where you live matters. We certainly serve a diverse population of children from urban, suburban, and rural areas of North Central Florida. There are urban-rural differences in injury mortality, and one of the reasons we collect the data on the kids that come with trauma is to look at those outcomes. And so this can be related to different activities, different safety equipment, practices, the built environment, or access to care. As an example, 14% of children under age 17 live in rural areas, but these rural residing children account for 24% of all childhood injury deaths in the United States. We use the term morbidity to talk about what you live with. So that was mentioning death, but even more children are injured who live with that injury. As an example, of the 20,000 children who present to the care in the ED for firearm related injuries each year, for every child killed, more or seriously injured, 50% of children hospitalized for a firearm related injury are discharged from the hospital with a disability. Injuries are all around us. It's in the activities that our children engage in sports, in fun. It's hard to get away from injuries, but prevention is key. So one of the things we hope to do in this webinar is to talk about 5 specific injury patterns that have a way to prevent their severity. We'll go over some of the data and some of the tips and tricks and resources. We're specifically going to talk about motor vehicle crashes and car seat and seatbelt safety, swimming and drowning injuries, helmet use and recreational vehicles, firearm safety, and burn safety.
Thank you, Dr. Petroze. I will start by talking about motor vehicle collisions. My name is Faida Badru. I was already introduced by Dr. Petroze as well. According to Centers for Disease Control, the CDC, there's about 608 deaths in children under the age of 12 every year. In particular, about 91,000 injuries occurred in that same time frame. And most of these children had no safety restraints. In fact, 38% had no safety restraints, of which, when you look at the age breakdown, most of those were the older kids. It was also noted that when the driver is unrestrained, it is more likely that the children who are the passengers in the car will also be unrestrained. So about 2/3 of the children who drove with the driver that was unrestrained also happened to be unrestrained. We talk about having no restraints, but it's also important to have appropriate restraints. There was, according to the CDC, about 46% of patients that sustained an injury or subsequently died actually had improper restraint. So they had some restraint, but it just was not appropriate either for the age or for the situation. And it was found based on multiple studies that if you use car seats appropriately, the injuries that occur in children can be reduced by about 76 to 81% when compared to using a seatbelt only in a patient age that was more appropriate for car seats. Booster seats tend to reduce injury by about 45%, and seatbelts reduce the risk of serious injury by about 50%. So it is important, like I mentioned, to make sure that you're using the correct equipment for the size of the child and the age of the child. So depending on the age of the child, you need to make a decision about what restraint to use. So for example, from birth to the age of about 2, really up to the age of 4, if the child still fits into it, you want to have them sitting in a rear facing car seat with 5-point restraints, as shown in the picture here. Once they're outgrow that, or they're over the age of 2 to 4, then you want to put them in a forward-facing car seat, again, still with a 5-point restraint. After outgrowing that, then you have them in a booster seat until their heads is actually kind of well fitted into being able to just have a regular car seat. And then once you're outgrown that, then you can have them in a regular seat with just seat belts. Always remember to make sure that any child under the age of 12 is seated in the back seat, never in the front seat, with these restraints in place. So some safety tips in general, like I mentioned, you want to use the car seats and the booster seats appropriately, and you want to install them appropriately. There are a lot of places that can assist with appropriate installation, including firefighters, hospitals can assist with installation of car seats. And also, like I mentioned, you do not want to see the children in front of an airbag. So usually the back seat is the better location for children. If you can, buckle the children in the middle of the back seat. And that, for me as a parent, definitely always is something that I keep in mind, because kids want to play with the doors and open the door sometimes. So sitting them in the middle of the back of the car helps sometimes with that. And proper restraint on every trip, regardless of how short you think that trip is very important. Also remember, like stated earlier, when you wear your car seat as a parent, you model a behavior that makes the children also want to wear the car seat. And like I mentioned, children who are seated with parents or caregivers who have a seatbelt on are also more likely to wear the seatbelt. So as a parent or caregiver, always remember to wear your seatbelt as well.
Good afternoon, everyone. I am Jordan McKean, and I'm going to be talking about head injuries, specifically those that can be prevented when children wear helmets. So protect your head in big letters. Obviously, we want children to protect their brain and their growing brain. So definitely need to wear helmets. We found that children age 5 to 14 have injuries that are associated with bicycles more than any other sport or little sport utility vehicle. But obviously, it's not just bicycles where children need to be wearing helmets. Children also like ATVs. We see quite a few ATV-related traumas here in Florida, and the U.S. Consumer Product Safety Commission reported that 14,000 children under 12 were in ATV-related incidents. And then this is also associated with a mortality rate, as well as 55 children under age 16 died in 2010 as a result of ATV-related injuries. A big reason that we want children to be wearing helmets is because it can help protect traumatic brain injuries, because these are treated in emergency departments at a rate of 500,000 each year. So getting into more about traumatic brain injuries, a traumatic brain injury, or TBI, is an acquired brain injury that's sustained via blunt or penetrating injury to the head. And in children, this may not be immediately recognized because pediatric brains are still developing. So it is hard to recognize in the immediate after effect of an accident if a child is even affected by a traumatic brain injury, which makes us want to avoid these more. These are obviously considered a chronic disease process, as the effects can keep going after the immediate post-trauma period. And sometimes if your children are affected by this, they may need lifelong medical and rehabilitative therapy. We grade TBIs based on a couple of things, one of them being loss of consciousness, another being what we use is the Glasgow Coma Scale, which is the most common scoring system for loss of consciousness after a traumatic event. So a mild TBI is if a child loses consciousness for less than 30 minutes, or their Glasgow Coma Scale is 13 to 15, 15 being pretty much normal after 30 minutes of injury onset. And then we also classify this as post-traumatic amnesia less than 24 hours. It's uncomplicated if we don't find any findings on a CT scan, any abnormal findings, but it's complicated if there are intracranial abnormalities on a CT or MRI of the brain. A moderate TBI is if someone loses consciousness or has post-traumatic amnesia for around 1 to 24 hours, as well as having a decreased Glasgow Coma Scale of 9 to 12. And then a severe TBI is a loss of consciousness for greater than 24 hours and post-traumatic amnesia for greater than 7 days, with a very low GCS of 3 to 8. These folks will often be in the ICU. So in terms of helmets, it's not just important to wear the helmet. Similar to car seats, we have to use our equipment properly. So step one of this is to make sure you have a good size. So you want the fit to be snug. And there's also sizing pads that are the foam pads that come in the helmets that can be used to help adjust your helmet size over time. Step two is the position. So you want it to be low on the forehead, 1 or 2 finger widths above the eyebrow. Step three, you want your side straps. So if you take a helmet, most of those side straps have a Y shape on the side, and the Y, or the end of that Y, should be right below your ear. Step 4, the chin strap. You should only be able to put 1 finger between your chin and the chin strap. And then finally, double check size steps 1 through 4 before getting your kids out on the road on a bicycle. This I found to be a very helpful resource. The CDC has their Heads Up campaign, which actually has, as you can see here, different links to different types of helmets for everything. Essentially anything that someone could hit their head. So whether that's baseball, lacrosse, skateboarding, anything that has a helmet associated with it, the CDC has guidelines for how that helmet should be fitted. So if you were to click on the equestrian helmet fact sheet, it would actually take you to a whole host of things about how you should get this helmet to fit, even things like how you should wear your hair so that the helmet fits snug on your head. So I found this to be a very good resource that we can use.
Okay, The next topic that we'll be talking about is pediatric burns. Every single day, about 300 children ages 0 to 19 are treated for burn-related injuries across the United States. And of these children, about 2 of them will die every single day. Younger children are likely to sustain injuries from scald-type burns, while older children are more likely to sustain injuries from flame burns. I think we lost this.
Pulling that up, my screen, yep, just died there. Let me just recover that. My computer shut down on that.
All right, that looks good.
Perfect. Okay.
Awesome. Thank you. Okay. Okay, next slide, please. Thank you. Okay, so some safety tips. Always be alarmed, and this is just a reminder that you should have smoke alarms set up in your house, just so that you can monitor and make sure that you know if there's any evidence of a burn. You always have to have an escape plan, and it usually is helpful to share this escape plan with the people that you live with, including your children. Have them practice it out to know what to do in the event of a fire. The third thing is cook with care. It's amazing to have your children helping in the kitchen and all of that, but it's also great for them to understand safety tips and cooking with appropriate handling of hot items and appropriate supervision. Always check what your water heater temperature is before putting a baby in a bath or before allowing a kid get into a shower. And most importantly, be vigilant, especially around little children who like to pull things, just to make sure that they're safe around hot items. So in case you have a situation where you have a pediatric burn, what should you do? Well, our pediatric burn center, which is one of the level 1 burn centers, is located at 1600 Southwest Archer Road, same as our emergency department. I put the phone number here just as a quick resource. In the meantime, if you have a burn that, especially a scald burn, you want to flush the burn area with cool, not cold water, just cool, almost like room temperature water for a few minutes. And then you want to call 911 if you have a severe burn, especially if there was an inhalation component to it or it happened in a closed location. If you have a minor burn, you can, after flushing with cool water, then present to the emergency department. And sometimes applying burn ointment to the burn in the meantime, prior to presenting to the emergency department, helps. And then pain control with some acetaminophen or ibuprofen for pain also help. Again, it is important to have these burns evaluated by a burn specialist, because even seemingly minor burns can deepen and become something that becomes more of an issue.
So this wouldn't be a trauma prevention talk in Florida without talking a little bit about water safety. So 945 children under the age of 20 die every year from drowning. And about half of those are infants and toddlers under age 5. From 2017 to 2019, Florida was actually the highest ranked state for accidental drowning death rates among children aged 1 to 4 years. Some ways that we can prevent this is in big group gatherings where children are playing and we have adults that are able to supervise. It's instead of having one adult that supervises at one time or for the entire time, it's sometimes easier to have adults switch out. So one adult watches for 30 minutes and then another adult takes over for the next 30 minutes because it is hard to be the one that is vigilant and watching the entire time. Also, it's important that if there is an adult who is supervising children in the pool, that adult is not consuming alcohol or anything that could possibly put them under the influence. Another great thing, as you can see in this photo, is investing in an isolation fence or gate around the pool. Something that probably could be locked is better, as kids are smart and they're able to get into a lot of things. In terms of life jackets and water safety when you're out on a boat in lakes, state laws vary, but the federal law does require that all children under the age of 13 wear a life jacket anytime they're on a boat that is moving. I would argue that they should probably be in that life jacket when it's not moving as well. And then for every boat, a life jacket should be available for each passenger, no matter how old they are. And knowledge is obviously power when it comes to most things in terms of prevention. And one of the best things to do is enrolling children in swim classes. And they can do this as young as 1 year of age. And not only can you put your kids in swim classes, you yourself can take classes such as CPR classes, so that if you were in a situation, a drowning situation, you would know how best to respond.
Okay, I'm going to talk about firearms next. So every year, about 1,300 children are reported to die from firearm injuries. Most of the victims of unintentional shootings tends to be boys, and they usually are shot by a friend or a relative, especially a brother. About 40% of all unintentional shootings in 11 to 14-year-olds occur in a friend's home. Another interesting fact is that adolescents are at a higher risk for suicide or successful suicide when there's a gun in the home. And when we discuss firearm injuries, there are a number of myths that I would just like to discuss real quickly and just kind of back it up with facts about what is actually true. So the first one is that hiding guns will prevent children from accessing them. Actually, studies show that about 75% of children who live in homes with guns know exactly where the guns are stored. Okay. The second myth is that children are not capable of firing a real gun. Actually, studies show that children as young as 3 years old are strong enough to pull the trigger of a handgun. The third myth is that children know the difference between real guns and toy guns. About 16% of unintentional firearm deaths among children younger than 13 years of age happen in situations where children thought that the gun was a toy gun. The fourth myth is that a child would not touch a gun because he or she knows better. Multiple studies have shown that most children will handle a gun if they find one, even if they've been told not to handle the gun. And the next myth I wanted to mention as well is that non-powder guns like a BB gun or a pellet gun or a pin gun are considered as toys. And this gun, which can actually fire at the speed of traditional guns, lead to about 22,000 injuries every single year, especially injuries to the eye. So although they might not have the same firepower, they do lead to significant injuries, and they should be considered same or not just toys. So some safety tips. One is consider removing all guns from the home if you can, something to think about. And if you do have a gun in the home, try to keep it unlocked, unloaded, locked, and out of reach and of sight of children. And you want to try to keep the ammunition and the guns locked in separate locations and not together. Safety devices, including gun locks or lock boxes or gun safes, should also be used for every single gun in the house. Storage keys and lock combinations should be hidden from children, and they probably should be changed periodically to avoid the children from learning what the combinations are. And then before visiting friends and relatives, you do want to ask if they have guns in their homes. And if so, just make sure that they keep their guns unloaded and they're locked as well and as protected as you would keep your guns unloaded and locked away. And finally, never leave children unsupervised in a home with a gun.
So we want to leave some time for questions, but hopefully what this has done is to review 5 different types of injury mechanisms in children that are preventable. And I hope that each person listening to this, whether now or later, will take at least one, and since it is National Injury Prevention Day, I'm going to challenge you to take 2 out of the 5 mechanisms. Take that home to your children, your grandchildren, your neighbor, your friend, your sister, your brother, with one individual with each of those 2 that you're going to look at, and double check the safety of a child car seat, of a helmet, of water safety, burn injuries, and firearm safety. Because as we know, accidents and injuries happen. Some are preventable, many are preventable. Unless we think about the ways that they're preventable, we can't prevent them. So do your part to educate and empower your children to make safer choices. Be part of that decision to make safer choices yourself so that you don't have to meet us with the pediatric trauma team. And stay up to date on safety recommendations. Pediatricians have these. The Centers for Disease Control and Prevention has excellent resources, as some were mentioned in the presentation. Additionally, the different children's safety networks and the American Academy of Pediatrics stay up to date on various safety recommendations. Ask your pediatrician for help or ask us for help. And we would be happy to answer any questions at this time.
Okay, thank you for those great presentations. Appreciate it. We did have a question that came in. Someone asked, they had a question about the Glasgow Coma Scale, the GCS scale. They said, how do they rate an injury? Is it a machine? Is it an observation? Is it a measurement? How does that work?
It's a great question. So this is a scale that we use at initial evaluation or repeat evaluation that's based on physical exam findings. And so we look at 3 different categories. One is eye-opening. And so everyone has probably interacted with someone that had a concussion or had a head injury because they're so common. And so the first is to see, are they opening their eyes when you call their name out? Do people open their eyes spontaneously, or are they not responding? Another is their verbal response. Will they respond appropriately, or are they sounding confused? Are they just making sounds or noises, or are they not responding? And then the final component of that is the motor response. And that motor response is that if you tap them, do they reach for you? Are they making posturing that indicates a more severe head injury? And we put these 3 categories together. So the lowest score that you can get is a 3. And that is essentially comatose or even brain dead. And there's different testing for that, whereas a 15 is normal. And so you put those 3 components together And we use this to reevaluate how a patient is doing from a head injury standpoint. At initial presentation with a head injury, their motor response is most predictive in severe head injuries of their overall outcome. And if they have a Glasgow Coma score, as Dr. McKean pointed out, of less than 8, this is considered a severe traumatic brain injury. And oftentimes these patients need to be intubated with a breathing tube in the intensive care unit. And these are pretty significant injuries.
Okay, thank you for that. Someone asked a question. Can you suggest a good way to ask a new friend's parents if they have guns in their home? I feel it's an awkward question to ask. I know I completely agree with that.
How do you ask?
I'm sorry, what did you say?
I said, how do you ask?
Well, I think that a lot of the times, volunteering the information in terms of what you do in your home with guns and gun safety to start with helps to get people to a point where they're comfortable enough to share that. So, oh, hi, you know, in our house, we do have some guns. We like to leave them, you know, unloaded and locked away, or we have no guns in our house. Do you guys have guns in your home? Oh, okay. You do? How do you, you know, how do you ensure safety with, you know, with the guns, and are they locked away and things like that? Now, as mentioned, it might be a little awkward the first time to the first person that you're asking. But I think similar to a lot of more conventional things that we talk about, things like car seats and things like that, I think it usually is pretty understandable if you're going to carpool. If someone asks, hey, do you have enough car seats for all the kids that are going to be in the carpool? So some of it is just sort of practicing that and understanding that it's you know, it's not a judgment, it's just sort of a safety thing. Is, oh, okay, it's fine, you have cars, you have guns in the home, but then how do you manage it? Because here are some suggestions that I might have, even though maybe we don't have guns in our home, but that sort of stuff.
I think that is a fantastic question about how you ask. And I would encourage to ask about multiple areas of safety. And so, you know, if your child is going to someone's house that they haven't been to, or to ask, who are the adults that are home? We live in Florida, a lot of people have pools. So asking about, is there a pool at the house? Do you know, what's your water safety plan? Do you have any, I always check before my kids go anywhere, if there's any guns in the home, and ask about the safety for that. And so if the more routine you make it, and the more you say, you know, my child hasn't gone to your house before, there's a couple of questions I always ask, and kind of go through that. So that's, I think that's kind of the easiest way, and just asking other people how they ask too.
Some great advice. We had a person from the audience said a way they approached it. I thought this was great. And they said, I think if they have a pool or maybe a situation, I would ask about a pool first, and then I can work my way into firearms, because that seems a little less awkward. I know I had someone I have 3 kids, and someone dropped their kids off at my house, or child off at my house one time. And that person was a police officer. He had a whole lot of questions for me. And I was like, you know, it was fine. I didn't mind asking them, but it was the first parent, I think, that ever really had a lot of very specific things they wanted to ask me about. And I didn't mind. I was happy to ask it. And I'm sure it wasn't awkward for them, because, you know, I think sometimes I remind myself it's a lot easier to ask this now than to deal with it when it's a problem. That's just me as a parent. So we have another great question. What's the role in the team as the trauma team of a child life specialist? How do they help with pediatric traumas?
Wow, that's such a great question. I'm glad that somebody asked that. I'm going to let Dr. McKean answer this one.
Yeah, so child life specialists, they hold a great role on the trauma team, especially in pediatric traumas, because it is a jarring experience, I think, for a child to come to the hospital, but certainly to come to our emergency department or trauma bay, where things can be pretty hectic. Everything's moving fast. There's a lot of different people with assigned roles, and I think it can be overwhelming. And child life specialists are there first and foremost. They, I think, ground and center the child. They say, you know, this is who I am. What's your name? How are you? They kind of bring them into the conversation and give them a place so that it's not just hectic and chaos running around. It's, I am here specifically to talk with you. I'm here specifically to make you feel seen and heard. And I think something else that they do that's really great is they can explain things like, oh, this is your doctor. This is a normal process that happens here in the trauma bay. This is an x-ray that we're taking. Or, you know, once this is done, we're going to be moving you over to the pediatric emergency department. And over there, we have things that are, you know, brightly decorated and look a little bit more like a pediatric hospital. They can also ask questions about who they were with in the accident, you know, mom and dad, so that they know that we're thinking too, that we want to get them a familiar face as soon as possible. So it's, and Dr. Petroze and Dr. Badru, please feel free to add more. But I think the child life specialist as sort of the guide for the pediatric patient while they're in the hospital, the person that's there to explain things, make them feel comfortable. Yeah.
Great. That they do such a great job. Not only in traumas, but I've had them out doing several different things in the communities for people to see what they are and how they take really complicated and scary things for children and the parents sometimes and break them down and make it so they understand them and be their advocate and be their voice, because it's a scary time. So I appreciate that. I don't have any more questions out there at this moment. So if anybody has any, please let me know. But I do want to thank you guys as we get ready to wrap up here for the time you've taken out of your day and for all the hard work that you do, and for taking such great care of children in not only our area, because we get traumas from my daughter's in the trauma unit as a nurse in the ER. So we get traumas from everywhere. And it's amazing to me the variety of different things that can happen to people. And so it's so important to talk about prevention, and it's so important to bring awareness to things. Like before I started working here, I never would have thought about children walk through fire a couple of days after someone's had a campfire and burn their feet. It's just something I never would have thought of until I was out somewhere and that was a topic they were telling people about. And I thought how important that is. So it is important. There's so many things we don't think about as parents. We all want to do our best usually, but sometimes you just let your guard down or you don't think about it. Or like you said, they're with a grandparent, they're with a friend, we're relaxing, and we just don't put that at the top of mind. So I do want to thank every one of you. And I got some comments in from a couple different people. Thank you to each one of you. And they really appreciate the topic. It was very valuable. So like I mentioned earlier, I'll send out a link to the recording, and thank you for your time today. Bye.
Thank you for hosting things, Marcia. I think that we're just excited to be able to reach out to the community. I think that one of the keys is that children are not just little adults, and they need specialized care. And that includes what we do with the training with our trauma team and injury prevention. And it really is a community effort with the various EMS services and firefighters and pediatricians and everyone in the region that is doing their part to prevent these injuries and to make us less needed for those acute injuries. But when they are, we're here for the kids.
Okay, thank you, everyone. Bye-bye.
Bye.